Hello guys, in this video we are going to see the uh, anatomy of the inner ear guys. um, okay, let's quickly rush to the topic. Okay, this inner ear consists of two parts guys, bony labyrinth and membranous labyrinth. If you know the embryology, this bony labyrinth is derived from the aortic capsule and membranous is derived from the aortic vesicle. Based on the function, inner ear is basically divided into two types: auditory part, cochlea; vestibular part, consisting of semicircular canals guys, and two sacs. Basically this cochlea is made up of a spiral structure. This axis, spiral axis, is known as modulus. Then this remaining part is the vestibule, which contains three semicircular canals and two sacs, namely utricle and saccule guys. Okay, uh, then the three semicircular canals are posterior semicircular canal, then lateral or horizontal semicircular canal, then anterior or superior semicircular canal. This we are going to see in the cochlea guys. The space between bony labyrinth and membranous is filled with perilimb. The space is known as perilymphatic space. Whereas membranous labyrinth is filled with the endolimb, is known as endolymphatic space. The space is called. Usually this horizontal lateral is not exactly lateral horizontal. So if you want to make it this as horizontal, you have to bend your head by a angle of 30 degree guys. Okay, this if when you shake your head like this, horizontal movement, it stimulates the horizontal semicircular canal. When it is overstimulated, it may cause horizontal nystagmus. Then if you want to make the lateral semicircular canal as a vertical, you have want to turn your head backwards by 60. This is forward guys, you need to bend forwards. This is backward by 60 degree guys. This is backward. This is a normal. Okay guys, normally this vertical movement is posterior semicircular canal is responsible for this vertical movement. Okay guys, it causes vertical nystagmus. We can see this in a later. Okay guys, also if your patient is in a supine position, if you want to make it this patient is supine position, the lateral semicircular canal will come to a position at an angle of 90 degree. 90 degree means sitting, lying means it becomes 90 degree. Then if you want to make it as a horizontal, you want to bend backwards by 60 degree, and if you want to make it as a vertical, you want to bend forward by 30 degree. That's it guys. Normally this is a zigzag movement stimulates the superior canal guys. Okay, this may produce torsional nystagmus. Each canal has an ampullated and not ampullated end. Wait guys, you can see this, and this is known as ampullated end. This is known as ampullate. This is ampullated end. Another small ends known as non-ampullated ends. Okay, this the non-ampullated ends of superior and posterior unites to form a crus commune guys. You can see the crus commune. This from the superior and the posterior commutes to form crus commune. The ampulla, this is a sac. It is it contains crisp ampullaris. It is the individual hair cells, and if this in entire unit is known as cupula ampullaris. This entire cristae. And no fibers are connected to this. This ampulla is responsible for the angular acceleration. When you are in angular acceleration, this cupula will be cristae ampullaris will be stimulated guys. Okay, then as I said earlier, this lateral semicircular canal, if any irritation to the semicircular canal will produce nystagmus, especially the lateral semicircular canal if stimulated, it causes horizontal nystagmus. Posterior semicircular canal if stimulated, it causes vertical nystagmus, and superior will cause torsional nystagmus. You have to know about what is nystagmus. Normally in a vestibular ocular reflex, there is the vestibule and either connected in known as reflex, known as vestibular ocular reflex. Normally if you are on a movement, if you want to focus eye on a point, eye focus on a point when head is moving. But if the semicircular canal is stimulated without a movement, it causes eyeball to adjust, and in the stationary position will have the eyeballs rotating or moving due to the defective vestibular reflex. Okay, this is not nystagmus. Okay, nystagmus is an involuntary rapid to and fro movements of eyeball. There are two types, peripheral and central. Usually we study in here about the peripheral. This is the vestibular part and this is the cerebral part. the SSC is defective, it is vestibular. If the any nerve fibers is defective, it is known as, it will be cerebral or central. Okay guys, the peripheral nystagmus has 5 characteristics. It is known as 5D's characteristics. There will be delay. If stimulus is stimulated, it causes some delay, after which it arrives the nystagmus. There will be a specific duration of the depending on the stimulus. There will be decay. On repeated stimulus, it may die off. Decreases on gaze fixation. When fixed to a point, it will become stopped. Then direction, there's two direction, fast and slow components. The fast component will give the direction. This vertical nystagmus can be down geotropic, that is towards the earth, or ageotropic upbeating nystagmus. This torsional nystagmus may be clockwise or anti-clockwise. This vertical is due to, as I said earlier, this posterior. This torsional is due to superior semicircular canal. Then we are going to the sacs, ventricle and saccule. It detects the linear acceleration, guys. The cristae ampulla detects the angular acceleration, whereas the ventricle and saccule detects the linear acceleration. It contains a macula, sensory epithelium of ventricle and saccule is covered by. It consists of hair cells with the otoconia. This otoconia nothing but a calcium carbonate crystals. This ventricle detects horizontal linear acceleration. If the movement is in like this, it can detect, whereas the cycle detects the vertical linear acceleration. Let's go into discussion about the BPPV or benign paroxysmal positional vertigo, or otolithiasis, or canal lithiasis, or cupulolithiasis. This is due to, you can see this otoconia. No, if this otoconia goes into some parts like some semicircumference, like posterior or lateral, or superior, it will cause us a vertigo. Vertigo, guys. This due to change in head position, this appearance is known as benign paroxysmal positional vertigo. Diagnosis is done by Hall-Pike's maneuver, guys. I will share this later. Okay, this is the Hall-Pike's maneuver. It is used with is the diagnosis for the benign paroxysmal positional vertigo. First, the patient is made to sit. We need to hold the head, then turn the head by 45 degree. Then we have to get them in a supine position. Then it will be if the patient goes for a vertigo, this is a diagnosis for BPBH. BPBV. Okay, guys. Then the treatment is this is the Apley's maneuver. First you have to sit. Okay, sitting will treat about 80 to 90%. Then you need to see the, you need to, in bed you need to see the roof of the room. Then you need to turn the head towards the left side and see the left upper corner of the room. Then the opposite to the right side. Then you need to sit again. Then you need to repeat this procedure. This will cure the BPBV. Okay, guys. Then when you see the other manuals for treatment, there will be Simmons or laboratory maneuver. It's not followed now. I guess it's the changing this opposite direction in the bed of the supine position. Then there will be a Fowler's maneuver. We need to lay down it about for 24 hours. Is bent by 45 degrees. Repeated BPV attacks recommend patient for some exercise. It is Bradant Daroff. If you do the exercise repeatedly, you can be stay away from the BPPV. Like you need to sit for 30 seconds. Then we need to, on the left side we need to in the bed, then the sitting position again for 30 seconds on the right side of the bed. Then lateral canal, especially for lateral canal BPPV, this we seen for a posterior canal. Then if we come to the lateral canal BPV, we can do two maneuver for treatment, like Lambert's maneuver, log roll, or barbecue maneuver. See, this is the barbecue maneuver. The person is total lying down on a left side, then straight, then the opposite side, then in a on hand or knees. Then The test for vestibular labyrinth will be first the caloric testing. As I mentioned earlier, this vestibule is very sensitive to temperature changes. So if you want to clean the external EAC, you need to use it water at 37 degrees Celsius. If you use it as 30 degree or cold stimulus, the vestibule will be stimulated. For warm also 44 degrees Celsius, this vestibule can be stimulated. When if the stimulus is cold, the vertigo will be nystagmus will be in the opposite direction. That is, if you give in the right side here, the nystagmus will be from towards the right side. Okay guys. Then if you give the warm, there will be same side of lateral, the same side of giving, there will be warm stimulus, warm nystagmus. This is known as modified copraxis or cold caloric test. Okay, this is, as you can see, for cold water by syringing, we are giving the external temperature decreasing, moderate temperature decreasing, stimulus lateral semicircular caloric stimulation, then horizontal nystagmus. This opposite is due to fast component in direction of the giving stimulus, guys. Okay, this syringing is contraindicated and perforated tympanic membrane. In that this condition, you need to follow the Dundas Grant test, that is, cold air is blown through a copper coil tube. Yes. Then the second test is the vestibular evoked myogenic British. That is, we giving the some response current. There are two types. If there is cervical hem, there is no cervix, you need to give the current or potential. Then ocular surrounding the ocular muscles, oculi. This cervical lymph is given in the sternocleidomastoid. It evaluates the sacral and inferior vestibular nerve functioning. This oculi, you can see S for S sacule, sternocleido, I for inferior vestibular nerve, oculi, U for utricle, and oculus S will be there, so it will be superior vestibular nerve. Then other test is galvanic vestibular stimulation, where the small voltage current is given and checked, and the values will be checked of the vestibular nerve. Then we are going to the auditory labyrinth. Auditory part is the cochlea. Yes, as I said earlier, the membrane between this bony labyrinth and membranous labyrinth, this is containing the perilimb, guys, whereas the between two membranous labyrinth, this is the contains the endolymph. The two membranes, as I said, this is the Reiser's membrane and this is the basilar membrane. Between this is the endolymphatic space. This endolymphatic space contains the basilar membrane, contains the important organ of hearing. This is the organ of corti. Okay, so the below portion is known as the scala tympani, between the bone and the basilar membrane. The between the bone and the Reiser's membrane is the scala vestibuli, and the endolymphatic space is the scala media containing endolymph, guys. Okay, as I said, this is the divided by vestibule, scala media, scala tympani by Reiser's membrane, basilar membrane. This scala vestibule and scala tympani is filled with perilymph. The space is known as perilymphatic space. Scala media is filled with endolymph, and the space is endolymphatic space. This endolymph is secreted by stria vascularis. This there will be a membrane here, membrane around here. This is known as will be known as stria ampullaris. This secretes the endolymph. Okay, guys. In the stria vascularis, there will be exchange of 3 Na plus with 2 K plus will take place. This produces the potential known as endocochlear potential. It is a DC potential. This there will be positive current due to excess K plex, and the other two spaces will contain negative charge. Okay, guys. As I said, this is the scala media. This is the Reiser's membrane. This is the basilar membrane. This apex is known as helicotroma. This is a uncoiled. This will be a coil, no? So I have, this is the diagram represented as uncoiled. And the scala media is connected to the CSF or supranuclear space via a duct known as cochlear aqueduct, guys. Then another important is very important, the drainage of endolymph from the cochlea. It goes into the ductus reunions. It goes to the vestibuli, especially saccule, then endolymphatic duct, then endolymphatic space sac will be there. It is present in the posterior wall of mastoid vase at a point near the joining of Donaldson line and the sigmoid sinus. You can see in the diagram, guys. This cochlear aqueduct has an important clinical role because if there is any infection of the subarachnoid space like meningitis, it will be the most common route of infection from vein to inner ear. So it will cause labyrinthitis. Labyrinthitis is the inflammation of the inner ear. It may be serous or suppurative. Clinical features will be vertigo, tinnitus, sensorineural hearing loss, as there is the auditory part. Okay, then let's go into the organ of corti. It is present in the basilar membrane, as I said above. There are two types of cells: outer hair cells, and inner hair cell. Outer hair cell and the inner hair cell. The outer hair cells are more in number, like 13,000 to 14,000, whereas this inner is 3,500. No, this is more in rows. There will more rows. It is present as single row. It develop early. It is a tubular shaped. It is a flask shaped. It is more sensitive to NIHL. Very important, guys. So the outer hair cell will damage it by the noise induced hearing loss. NIHL means in NIHL the stereocilia is the outer the finger like projections of the outer hair cells. And then the ototoxic drugs may affect the cochlea, especially the hair cells. First, the most common ototoxic drug is the aminoglycosides, causes irreversible damage. The drugs like streptomycin, gentamicin causes it is vestibulotoxic. It is toxic to vestibule. Drugs like kanamycin, amikacin, most commonly is cochleotoxic. Guys, this is irreversible changes. It produces irreversible changes, guys. You can see then loop diuretics like furosemide, which is a dose dependent damage it produces. Then platinum drugs, cisplatin, carboplatin. It may be reversible or reversible damage, guys. So this is the aminoglycosides. First will commence to the outer hair cell, commence to the iron. So this produces apoptosis of the iron hair cells, whereas this when it enters the RS pathway, it will be irreversible. But when in presence of cisplatin, first it combines with another molecule like CPMHC and NOx3, which is the initial phase. If the drug is stopped in the initial phase of NOx3, the process will be stopped as it is anti-apoptotic. But when it enters the ROS phase, then it will be apoptotic. So it may be reversible or reversible. Other drugs like mycobacterial, erythromycin, antimalarial, chloroquine, hydrochloroquine, quinine, NSAIDs, ibuprofen, and naproxen. Then chemicals like alcohol, tobacco, marijuana, carbon monoxide also causes ototoxic. Then other miscellaneous drugs like ampicillin and dextroaroxatinate. Then these outer hair cells normally produce a sound or known as autoacoustic emission. This we can't hear. These are very low intensity sounds in response to a sound stimulus. Normally there are two types of autoacoustic emission: spontaneous acoustic emission. There is even absence of this any sound stimulus. This will be heard. This will be there, but we can't hear that. It's of no use. It's of no use here because we can't tell whether the patient may be hearing or not, present or not present. The other may be evoked autogust emotion. It may be transient by giving single frequency sound or distortion. Distortion problem is a double frequency sound. This transient evocation is very most sensitive. You can detect the NIHL. Can give a sound stimulus. If the OAE is present, we can record that. It is the most sensitive test. Okay, guys. Then whereas double frequency is the most specific test. We can clearly say the patient has an NIHL or not. Then this OAE is performed as a screen test for neonatal deafness case. The ototoxic first affects high frequency sounds. Earlier high frequency audiometry was done for ototoxicity. Autonomous acoustic emission is the most sensitive test to detect ototoxicity. Thanks, guys. Thanks for the video.